See here. So in the last class, I talked a little bit about these vesiculobullous disorders, just the classification. So let me repeat again because we have a bit of gap there. So we should know about the vesicle and bulla first. Vesicle means the size is important here. The size of the vesicle is less than 5 millimeter and it is usually having clear fluid inside. Okay, the content of the vesicle is clear fluid. If that clear fluid is infected and converted into pus, we call that pustule. If that size is more than 5 millimeter, now we call it bulla. But bulla may not have fluid all the time. Bulla may be having air also inside. For example, bulla, okay, is present in the lung, and usually that bulla is having air, but bulla can have fluid as well. So this is the difference. Now, let's see this slide. This is a little bit of a revision for you. See there. This is, epidermis, isn't it? A detailed view of epidermis. See here on the top, these are stratum corneum cells. Then slowly we are moving downwards, and ultimately we have reached to the stratum basal layer. Okay, in between there are different types of layers. If it is a thin skin, there are 4 layers, and if it is a thick skin, there are 5 layers. Okay, now a Langerhans cell is shown here. Langerhans cell. What is this Langerhans cell? Let me ask you again. What is this?
Macrophage.
Excellent. This is very good. This is a type of macrophage, and it mainly acts as an antigen presenting cell here, because macrophage has
macrophage.
Exactly. So macrophage has 2 important functions. All of students know. 1, antigen presentation. 2nd is phagocytosis. So it is doing both function here, but the most important one is antigen presentation. These are the keratinocytes, which are the skin cells or epidermal cell, you can say. Okay, and one of the important point why this slide is included here, these keratinocytes are attached with each other with the help of desmosome. This desmosome is the attaching substance in between the keratinocyte. If this desmosome is destroyed, okay, or attacked by the immune system, then this keratinocyte can easily separate away from each other. Okay, they can be separated away, and that is the reason how they are forming vesicle and bulla easily. We'll talk about that later. This is the main concept of this vesiculobullous disorders. Then these are the Merkel cells. Okay, these are the sensory receptors. Melanocytes are shown here. Remember the structure of melanocytes. See there is one main cells at the center, and this cells has different types of branching process, which are almost looks like a dendrites. Okay, this is the main cell, and these are like dendrites. This look like dendrites. Okay, actually dendrites are the term we use in the nervous or nerve cell, but they almost looks like that. And through this branching pattern, the melanin pigment will travel to the different keratinocyte, and that melanin pigment is shielding the nucleus of those keratinocytes so that they will be prevented or protected from the damaging result from the sunlight or ultraviolet light of sun ray. So these are all things we have discussed before. Now this is even a better picture than before. Now see this. These are the different types of skin cells, or you can say keratinocyte, and these are the desmosome. These structures are called desmosome because they are connecting these different type of cells. Okay, they are present in the epithelial cells. Skin cell is a type of epithelial cell as well. This is called basement membrane. Okay, now this is the hemidesmosome, which is present towards the basal surface, and here is the desmosome. This is another picture which is showing in much more detail there. Okay, but the understanding is same. Now with this, let's talk about the classification. So classification of vesiculobullous diseases are roughly divided into two big headings. One is intraepithelial vesicle. All of you see there. First is intraepithelial vesicle, and here the lesion is formed within the epithelium. That's why it is known as intraepithelial. Now we again divide them into two parts: acantholytic and non-acantholytic. Now acantholytic means there is a breakdown of desmosome. Okay, breakdown of desmosome or destruction of desmosome, known as acantholytic vesicle. And the good examples are Pemphigus vulgaris and Pemphigus foliaceus. This Pemphigus vulgaris is an important topic which we are going to talk today. Among the non-acantholytic vesicle, they are mainly seen in different types of viral infection, like herpes simplex virus, varicella zoster virus. These are the good examples here. Another is subepithelial vesicles, mean below the epithelium. Okay, below the epithelium, mainly in the lamina propria region. So these are erythema multiforme, pemphigoid, also known as bullous pemphigoid, and then dermatitis herpetiformis. Now, this dermatitis herpetiformis is associated with one of the common disorder of the GI tract. What is that? Yes.
Celiac disease.
Celiac disease.
Very good. Celiac disease. Excellent. Celiac disease. Don't forget that. That's an important question in any type of medical exam. Celiac disease is an autoimmune type of disease which damages the villi of the small intestine so that food cannot be absorbed properly, which results in chronic diarrhea and malabsorption. Okay, let's move on. Now, let's start the discussion of very important part of today's class, that is Pemphigus vulgaris. In dermatology, vulgaris means common. So this is, you can remember, common type of pemphigus. Pemphigus vulgaris is an autoimmune disorder. It is very common in Ashkenazi and Mediterranean Jews. Now, Jews are the type of race in this world. Okay, Israel is the country which mainly have a Jews population, but they are scattered here and there. So because of some genetic predisposition, the Jews population are commonly suffering from Pemphigus vulgaris. They are mainly seen in middle-aged female. What are the clinical features? See here. This Pemphigus vulgaris is associated with painful ulcer or erosion. Okay, mainly present on the epithelium. Now, epithelium means outer surface of the skin or in the mucous membrane as well. Now, just think about, if it is formed in the oral cavity, then it can form very painful ulceration, and the person cannot, eat properly or cannot chew properly. There is a lot of pain. But if it occurs on the outer surface of the body, then it can rupture very easily because they are quite superficial. Remember the classification. These are epithelial type of vesicles or bulla. So they are present on superficial part of the epidermis. So they can rupture very easily and they can lead to ulcer or erosion. They are non-pruritic. There is no itching, but sometimes, slight amount of itching may be there. The bulla is rapidly ruptured, leaving a grayish membrane towards the upper part and a red ulcerated base. Sometimes this ulcer almost looks like an Aptos ulcer. This Aptos ulcer is a special term we use in oral cavity, and these are idiopathic ulceration. Okay, recurrent idiopathic ulceration in the oral cavity are known as Aptos ulcer. We don't know what is the mechanism of this ulcer formation. So there are different type of hypotheses though. Some, doctor believe they are because of some stressful reaction. Some believe they are because of some vitamin or mineral deficiencies. Some believe they are because of some infection or autoimmune disorder also. Okay, but frankly speaking, they are idiopathic. So this ulcer, because of pemphigus, almost look like Aptos ulcer. Don't think and the Aptos ulcer is caused by pemphigus. Okay, that's not the point here. It looked like that. One of the very important point is Nikolsky sign is positive. Now, we have studied this before, especially when we talked about Staphylococcal scalded skin syndrome. Okay, SSSS. During that time, I talked about that Nikolsky sign. Now, remember why Nikolsky sign is positive here. That's an important question asked to the students. Because the desmosome, which is attaching the cells there, is destroyed in this case. So those cells are relatively free from each other. They are not tightly adhered with each other now. So if I apply a bit of pressure tangentially means on the side, then the skin can be pulled out like a sheet of a paper. Okay, so this is known as Nikolsky sign, positive Nikolsky sign. It is not only present in Pemphigus vulgaris, it is also present in SSSS, okay, and even in toxic epidermal necrolysis. It's a type of drug reaction. Sometimes the ulcer are joined together and form a bigger one. Okay, this is known as confluence of the ulcer. And if this condition occurs in the oral cavity or in the mucous membrane, it is very painful condition. Even on the surface of the skin, it can cause a lot of pain. Let's move on. Now, this disease has a variable course. Okay, so we cannot really pinpoint what type of course it will follow. In some of the patient, it may behave differently. In other patient, it may behave differently. In some, it may only involve the skin, for example. In other, skin along with mucous membrane can be involved. Even cervix can be affected in female. So it may lead to cervical ulceration. Protein fluid, electrolyte, okay, and weight loss are because of secondary infection. A lot of things can happen here. Now let me explain why these things occur. See this vesicular bulla, if there are many, okay, if there are many, then there is a collection of fluid there. Now this fluid is a exudative type of fluid. It is a protein rich fluid, and after some time they will be ruptured. So the patient can lose a lot of protein rich fluid from the surface of the body. Okay, so it may lead to hypoproteinemia. Electrolyte loss can be there. Now because there is increased evaporation, the skin has been denuded, the skin has been lost, so more evaporation from the surface of the body. And then secondary bacterial infections are also quite common. Okay, it's very easy to understand. Staphylococcus aureus or Streptococcus pyogenes are the two most common bacteria which can lead to superficial secondary bacterial infection. Nails can also be affected in Pemphigus vulgaris. It can lead to paronychia. Paronychia means infection of the nail bed. It can lead to subungual hematoma or even dystrophy of the nail. Now, both fingers and toes have been affected by Pemphigus vulgaris. Remember, there are so many other conditions which can affect the nail also, like any example, which type of skin diseases affect the nail? Yes.
Psoriasis.
Very good. Psoriasis is one. Very good. Tinea unguum we say, or onychomycosis. Excellent. That is another one. Exactly.
Iron deficiency anemia.
Exactly. Very good. Iron deficiency anemia, which is known as koilonychia. Excellent. Okay. And one more I want. Remember, in the few days ago we talked about alopecia. Which type of alopecia is associated with involvement of the nail? Yes.
Areata.
Very good. Alopecia areata. See that? So these are the different things, which comes as a differential diagnosis if nails are affected. And this type of questions are quite favorite of the examiner. Now, let's see some of the picture here. Okay, how this Pemphigus vulgaris presents. Look at here. Look at the amount of skin surface it has involved. The buttock region is affected. Even the anal mucosa can be affected here. And see this, I cannot see any vesicular bulla now because they are already ruptured. They are ruptured because they are very superficial. Okay, so they can rupture easily, leaving behind the ulceration. So protein-rich fluid can be easily lost from here. Secondary bacterial infection may occur here. Very painful condition. Okay, and the person can lose fluid and electrolyte also from these areas. See there, you can still see a bit of collection there. Okay, you can see this as a bulla here. See, it has just shrunken. I can still see the traces of the bulla here. So this is another picture. Now see this. Okay, there is another picture. Most of the bulla and vesicles are ruptured here, and this is the mucous membrane. See this, these are the teeth. So this is the oral cavity towards the palatal area. Look at the ulcers here. Okay, these are the ulceration. Now let's talk about the pathogenesis of Pemphigus vulgaris. Now, you already know what is this pathogenesis all about. This is an autoimmune disease, and we do not know what is the cause here. So this is mainly of idiopathic nature, but some hypotheses or some precipitating factors involved here, like AC inhibitors and penicillamine. Sometimes they are associated with Pemphigus vulgaris. So how do you understand? The person should be genetically predisposed first, number one. Number two, they should get this type of medicines, and these medicines just make them vulnerable for the development of the disease. If that person is not genetically predisposed, then they will not develop pemphigus after using this medicine. Especially AC inhibitor is very commonly used drug in the clinical practice. Very, very common drug. Can you tell me some of the indication of AC inhibitor? Yes. Which are those conditions?
Congestive cardiac failure,
nephrotic syndrome,
pulmonary edema,
proteinuria.
Exactly. See, some of the important answers have already come. Very good. One of the common condition is hypertension. This is one of the important anti-hypertensive drug which is used these days. Another important indication is congestive cardiac failure, okay, or heart failure. Simply you can say heart failure. AC inhibitor is very, very commonly used drug there. And some other conditions are like chronic renal failure and proteinuria. So if there is some type of disorder, where a lot of protein is getting lost in the urine, we can use AC inhibitor to decrease the amount of proteinuria. Like I can take an example of nephrotic syndrome. I can take example of diabetic nephropathy and even chronic renal failure. But okay, chronic renal failure is a two-edged sword here regarding AC inhibitor, because AC inhibitor can exacerbate that renal failure situation and convert chronic renal failure into the acute one also. Okay, so I should always check what is a renal function test before using AC inhibitor. So that is a bit of controversial type of indication, but if somebody asks you this question, then you can confidently answer, I want to decrease proteinuria in case of kidney disorders. That is the main purpose of using AC inhibitor rather than other thing. Okay, I like to monitor my patient with a renal function test, and if urea and creatinine are rising, probably I'll stop this medicine. That is the way. What is penicillamine? Where it is used? Where?
Wilson
Wilson
disease.
disease, copper chelating agent.
With heavy metals used in the Wilson disease.
Very good, very good. You guys, have a good concept. Excellent. Penicillamine is a copper chelating agent. So copper is a type of heavy metal. We all know that. So in case of Wilson disease or in case of copper overload condition, we keep penicillamine. It will bind with that free copper, and that copper can be excreted out. This type of drug is penicillamine. Remember, Wilson disease is the good answer here. Now, the type of antibody which are associated are IgG antibody here, okay, IgG, and these IgG antibodies are reactive against the desmosome, leading to their destruction. Desmosome is an attaching substance between the epithelial cell. So when they are destroyed, okay, the epithelial cells will lose attachment from each other, means they can easily separate from each other, and that is the main pathogenesis of Pemphigus complex. Now, if we take a biopsy and send it to histopathological exam, what we see there, okay, let's talk about it. There is formation of intraepithelial vesicle or bulla, and there are cleft-like spaces which are produced by acantholysis. Acantholysis means destruction of desmosome. So the cells are separating from each other. These changes are mainly seen in stratum spinosum or the prickle cell layer. This is one of the layer which is present in epidermis, stratum spinosum. So they are mainly seen there, and this is quite superficial one. The inflammatory cells are very scanty. However, eosinophils may be seen. So these inflammatory cells, they may be lymphocytes. Okay, they may be plasma cells, and sometimes eosinophils can also be seen. Now, one of the important point here is Jank cell. This is known as Jank preparation. Okay, so let's talk about them. This acantholytic stratum spinosum cell occurs singly or they occur in the forms of clumps lying freely within the blister fluid. These cells, they lose their polyhedral morphology. Rather, they become small, they become rounded, and they contain hyperchromatic nuclei. And we use the term Jank cells to describe them. Jank cell. These Jank cells are formed because of destruction of desmosome. The same thing comes here again. The cells become separate from each other, so they will become a bit of more spherical and smaller rather than polyhedral morphology. So these are called Jank cells. So Jank preparation means we see these Jank cells, and that will give us the diagnosis. Now, how it looks? See there? These days, this type of slides are quite commonly asked in the exam to the students, and they may ask what you see there. What type of disease comes in your mind like that? See here? See this? This is a basement membrane. All of you can notice it. This is a basement membrane. Now, look at these vesicles. See here. These vesicles are definitely formed above the basement membrane. There is a stratum corneum, the most superficial layer. So different other layers are there. Stratum spinosum, stratum granulosum, stratum basal, and things like that. So see there. So these are quite superficial vesicles. If they are bigger one, we call them bulla. That's why they can rupture very easily in this case. These are the Jank cells or Jank preparation. Okay, look how rounded they are. Usually epithelial cells are not this rounded one. Okay, they are not rounded one, but after they separate from each other, okay, then they look like rounded cells. Now, diagnosis, okay, is mainly a clinical one, but we can go for some other type of investigation like skin biopsy and histopathology. If we see those superficial vesicles in the epidermal area, then almost the diagnosis is confirmed. If electron microscope facility is there, then we can go for that particular investigation. It will show widening of the intercellular space, which is followed by a splitting of the desmosome junction. This is a very detailed type of investigation. Immunofluorescence study can be done. Immunofluorescence study is mainly done for antigen antibody reaction. Now, antibody is already present here. These are IgG type of antibody. This IgG antibody will go and fix onto the desmosome. So if we see this, desmosome antibody combination, okay, which is very easily seen by immunofluorescence type of microscopy, then we can get the diagnosis again. And another one is ELISA. ELISA means it is detecting antibody against the desmosome again. What are the differential diagnosis of Pemphigus vulgaris? Look at the familiar type of terms here. Pemphigoid, also known as Bullous Pemphigoid, is the most important one. Okay, I'll talk about this in today's class. Bullous Pemphigoid, is having deeper vesicle and bulla. Deeper. These are subepithelial one. So when the patient comes to us, patient is still having a lot of vesicle and bulla, okay, on the surface of the body or deeper inside. This is a big difference between Pemphigus vulgaris and Bullous Pemphigoid. Dermatitis Herpetiformis is another differential diagnosis. And this is one of the subtype of celiac disease. Staphylococcal scalded skin syndrome is another one, which is caused by Staph aureus, of course, and it is very, very common in small babies. Nikolsky sign is positive here. And toxic epidermal necrolysis. This is the most severe type of drug reaction. TEN, we call it in the short form. Here also Nikolsky sign is positive. Okay, so Nikolsky sign, if your examiner asks, you can remember these few conditions like SSSS, Pemphigus vulgaris, and TEN, or toxic epidermal necrolysis. Now, let's talk about what is the course of the disease. The course of all forms of Pemphigus is prolonged even with treatment. So this is a difficult disease to treat. The mortality rate is still at least 15%. 15% of the people may die because of different complications in case of Pemphigus. Superficial Pemphigus is less severe than the deeper one. And with modern treatment, most patients with Pemphigus can live relatively normal life with occasional exacerbation. Now, can you guess what type of medicine we use for the treatment now? Just go back to your pathogenesis and tell me what type of medicine we use. Yes?
Corticosteroid to decrease the inflammation.
Very good. Corticosteroid to decrease the inflammation or to decrease the chance of those antibody production. Excellent. So they are one of the main type of drugs in this case. If they cannot, treat properly, then we can go for some powerful immunosuppressive drug. Okay, some powerful type of immunosuppressive agent. Sometimes even monoclonal antibodies can be used. So see there, these are the different types of therapy. Now, regarding the complication, they are inevitable with the high dose of steroid and immunosuppressive drug which we use for the treatment. Now, these days, okay, we are having COVID-19 as a pandemic infection all over the world, and steroids are one of the major drugs which we use there, especially if the patient is having pneumonia, if the oxygen saturation is going downhill, and if the patient is having pneumonic patch, then steroids have to be used. They are very, very important drug. So we can see a lot of side effect of the steroid, especially how long we use them, So just similar type of situation. If we use steroid for a longer time in a higher dose, complications or side effect will be there in the patient. Now tell me, what are the important side effects of corticosteroid? Yes? What are those?
Bone marrow suppression. Bone marrow
Decrease
suppression.
immunity. Decrease immunity.
Osteoporosis.
Good.
Raoul symptom.
Good.
Cushing syndrome.
Good.
Cushing syndrome.
Very good. So see that so many important points have come from the student side. Excellent. Remember, this is one of the favorite question of any type of teachers, any. Okay, so let me quickly repeat them again. If we use corticosteroid for a long duration, okay, especially which type of corticosteroid we use, are they systemic or are they topical? It depends. Topical, they don't have much, side effects, but the systemic, they have a lot. Okay, one of the important is hypertension. Blood pressure will be high after the use of corticosteroid. Second is a peptic ulcer disease or gastritis. Don't forget that. That's why whenever we use corticosteroid, we have to give, proton pump inhibitor type of drug or H2 receptor blocker type of drugs together. Otherwise, the patient will definitely suffer from gastritis or even peptic ulcer disease. Another effect is in the bone. The patient may be having osteoporosis. Another effect is in the muscle. It leads to myopathy. We call that proximal myopathy. Steroid can also lead to problem in the eye. Okay, cataract and glaucoma. These are the two important problems in the eye: glaucoma and cataract. You'll study both of these conditions in ophthalmology. Okay, in the next semester. Very important topics from the eye side. Corticosteroid, okay, is a very, very important immunosuppressive drug. So the patient has a higher chance of getting different type of other, infection, like nosocomial infection, opportunistic infection. All of them are quite common in the patient. Never forget that. And one more, at the end, every student has to say that to the examiner. Otherwise, examiner will not be satisfied. Remember, we can never stop these corticosteroid abruptly. Okay, we should always taper the dose and then only stop, especially if you have used corticosteroid for more than a week time, more than 7 or 10 days. If we have given corticosteroid to our patient, don't stop it in 1 day time. You decrease the dose, use for another 1 to 2 weeks, and then only stop it. These are the very important points here. Okay, let's move on. Now, treatment we have already talked about. Just look at the name of the medicine here. These are systemic corticosteroids like prednisolone, like dexamethasone, like betamethasone. Okay, any type of steroid you can use. Start with a dose, then follow up the case. If you are not happy, you can slowly increase the dose as well. Along with that, some other immunosuppressive drug like azathioprine, okay, even cyclophosphamide or even methotrexate can be used. But these are very powerful drugs, so proper evaluation has to be done in the beginning. Now, after doing the discussion of Pemphigus vulgaris, there's another small type of topic which is almost similar to the Pemphigus vulgaris, that is known as Pemphigus foliaceus. Okay, so what is the difference? Let's talk about it. Pemphigus foliaceus is a condition where blisters are present high in the epidermis, either in the granular layer or just beneath the stratum corneum. So they occur even superficial than Pemphigus vulgaris. The antibody binding may have a direct effect on the function of the desmosomal cadavrin in the upper epidermis, causing detachment of the keratinocyte. So again, they are causing destruction or damage to the desmosome. Desmoglein 1 is present, but only weakly expressed in the mucosa, accounting for the lack of mucosal involvement in case of Pemphigus foliaceus. It means, just remember, it doesn't affect mucosa that much. Only the skin is mainly affected in foliaceus, whereas in case of Pemphigus vulgaris, both the skin as well as mucous membranes are affected. Now, regarding the clinical feature, mainly the skin is affected, and where? Mainly involve the seborrheic area. Now, this is an important term in dermatology, seborrheic area. Now, see here, there is scalp, face, chest, and upper back. Why they are called seborrheic area? Because seborrheic dermatitis is very commonly, occur in this area. Seborrhea, okay, is that white type of fleck which is present on our scalp hair. Many people are having it, seborrhea. Now, when this seborrhea fall, they fall mainly on these area which are highlighted here, and in the same area are having Pemphigus foliaceus as well. Though the pathogenesis of seborrheic dermatitis and Pemphigus foliaceus is very, very different. They're completely different situation. Only point which is common between them is the site of involvement. Blistering may not be obvious because they are superficial and may rupture easily. By the time this patient comes to us, we don't see any blister or bulla or vesicle because they are already ruptured. Why they are ruptured? Because they are very superficial. Oral lesions are uncommon, and pemphigus foliaceus is generally regarded as a benign disease which responds well to the treatment, but it may remit. Okay, well to treatment and may remit because of the good response to the treatment, but sometimes it may relapse later also, but the chance of relapse is rare than Pemphigus vulgaris. Now look at the picture before we go for the break. See here. There is no blister now, but I can still see the margin. See, this is the margin. Okay, there is an attachment of the blisters. I can still see some of the dried part of the blister here. You see this? This patient is having a bit of extensive type of involvement, but one of the important difference between vulgaris and foliaceus is the mucous membrane is not affected in foliaceus, whereas mucosa involvement is also quite common in vulgaris. Now, this is the histology. Okay, it is even more superficial than the Pemphigus vulgaris. See there? This is much superficial, right below. Now we are talking about Pemphigus foliaceus, and before the break we talk about the histopathology of Pemphigus foliaceus. Remember, the blisters or the vesicles are even superficial than Pemphigus vulgaris in that case. Now, what about the treatment? Treatments are similar. We can use corticosteroids, either a topical or intralesional, or even the systemic one. Okay, it depends on the situation. If there are very few type of lesion, we can go for topical, intralesional. Otherwise, we can go for systemic. Any types of systemic corticosteroids can be used, like prednisolone, dexamethasone, or betamethasone, like that. If they are not helping, then we can go for some powerful immunosuppressive agent. And even intravenous immunoglobulin can be tried. Now, after knowing these things, let's go to the another type of very important, vesiculobullous disorder, that is Bullous Pemphigoid. Now, this Bullous Pemphigoid mainly affects elderly population with onset after 60 years of age. So they mainly affect after the age of 60. Okay, remember, Pemphigus vulgaris usually affects females. Okay, middle-aged female, but this one occurring in the older type of population. It is more common than Pemphigus vulgaris, and the blister in case of Bullous Pemphigoid is subepidermal, and because of this important point, they are not easily ruptured. Means when the patient comes to us, those vesicles or blisters are still intact. Okay, they are still intact. So we can see more blisters than in case of Pemphigus vulgaris in this case. Bullous Pemphigoid commonly starts with itching and a non-specific rash on the limb that may look like urticaria-like rash or eczematous type of rash. Urticaria, okay, is a typical type of allergic reaction on the skin. They are swollen type of rashes there because of the edema formation. When we feel it, we can easily feel them, and they're very, very itchy, mainly caused by type 1 hypersensitivity reaction. Whereas eczema is also another term for dermatitis. There are very different types of dermatitis we have. Let's move on. Okay. Now, see here, the blisters, okay, in case of Bullous Pemphigoid, they may arise on erythematous and on a normal skin, and it may be associated with dermal edema because they are deeper, so they are associated with dermal edema. The blisters are tense and dome-shaped, okay, and they may obtain a diameter of many centimeters sometimes, means they are bigger in size, and they're tense. They're still filled with fluid, and they're difficult to break. The blisters are tough and may remain intact for several days, and the contents often becoming jelly-like with coagulated fibrin because it is collected there for a longer time. Okay, that is the simple reason for this. Mucosal lesions occur less frequently than Pemphigus vulgaris and are less severe than in Pemphigus vulgaris and are usually confined to the mouth and not in other mucous membrane. So one important point, they also occur less frequently, but they can occur in Bullous Pemphigoid. And even if they occur, they are less severe than Pemphigus vulgaris. Now look at the picture here. See this? Look at this, blister still seen here. Some of them are already ruptured, but a big bulla is seen here. It's another one here, okay, in this patient. Now, look at this. Still, I can see blisters. They are not easily ruptured. And look at the amount or the type of fluid which is collected inside. Okay, see there? Still not ruptured. Okay, see, I can still see them. So bullous pemphigoid, but you can easily, suspect Pemphigus vulgaris also here. Pemphigus vulgaris also here. So how to separate them? One of the important examination we do is examination of the mucous membrane. Okay, oral cavity may be affected, even in case of bullous pemphigoid, but that affection is not that very serious one. And especially pharynx, esophagus, okay, anal canal, they are not affected in bullous pemphigoid, but they may be affected in Pemphigus vulgaris. That is a clinical type of difference. Pathogenesis point is still there. We have to talk, okay, and some the other investigations are also there. Now see here, what is the pathogenesis? What is the difference from Pemphigus vulgaris? Bullous pemphigoid is also a type of autoimmune diseases. Okay, so serum from about 70% of the patient with the bullous pemphigoid contains IgG type of antibody, which bind in vitro to the normal skin at the basement membrane zone, that is the border of dermis and epidermis. Now, let me ask you one question here. What type of substance is there which attaches the epithelial cells in the stratum basal to the basement membrane? What is that attaching substance called in the basement membrane area? Yes?
Hemodesmosome.
Excellent. This is known as hemidesmosome. So this bullous pemphigoid mainly attacks the hemidesmosome component rather than desmosome, which is attacked in case of Pemphigus vulgaris. That's why it is deeper, because it is hemidesmosome is present way deeper than those desmosomes. Idiopathic, okay, just like Pemphigus, we do not know why this disease occur, and sometimes sulfur drugs are responsible. Sulfur drugs means sulfonamide type of compounds. This histology or histopathology will clearly tells us, okay, what type of condition is this. Look at this here. This is epidermis. Look at this basement membrane here. Okay. Now see this. Where are these gap present? See this? These are blisters. Okay. Now they are much deeper than those histopathology which you have seen before. On those two situations, they were much superficial. So this whole thing is there. Okay. Now regarding the course of a bullous pemphigoid, the untreated bullous pemphigoid runs a chronic and self-limiting course over a number of months or year. Self-limiting means even without treatment, it can get better on its own. The disease duration is usually 3 to 6 years, with most patients achieving complete remission even without treatment. But we'll do that, isn't it? If some patient is having these big type of blisters, vesicles, bulla on their surface of the skin, they'll definitely seek the treatment. And we doctor will try to find out what is this and try to prescribe some of the medicine rather than keeping them just like that. The treatment are similar. Okay, most of the treatments are similar here. See this? Topical and systemic corticosteroid are the mainstay of therapy of the treatment. For localized Bullish Pemphigoid, very potent topical steroids are often sufficient. If a small area is affected, then we can easily go for a topical steroid. But if larger area of the body is affected, rather than topical steroid, we usually go for the systemic one. Tetracycline or erythromycin with nicotinamide is alternative to steroid, but we really do not know how they help. Probably they help by causing immunomodulation, because we know, these macrolide type of antibiotic, they have immunomodulatory action, like azithromycin, erythromycin, roxithromycin, clarithromycin. They are the one. Even tetracycline may have the similar type of property. And nicotinamide, okay, is a type of vitamin derivative. Now, which vitamin derivative is nicotinamide? Which vitamin? Anyone? Yes.
Vitamin B3.
Yes. Exactly. Vitamin B3. Very good. Okay. Niacin, niacin. What do we want to say? Nicotinamide is the derivative of that. Now, the last part of this topic is a Dermatitis Herpetiformis. Let's talk a little bit about it. See there. Dermatitis Herpetiformis is a rare, intensely pruritic or itchy, chronic, recurrent papulovesicular disease, which is strongly associated with celiac disease. So this is a itchy, okay, chronic, recurrent, and it mainly has papule and vesicles together. Remember, papules are small type of nodules which are lesser than 5 millimeter in size. Okay, they are nodule actually. They are not filled with any fluid. They are solid type of compound or material. Whereas vesicle, you already know. There is an underlying gluten-sensitive enteropathy that may be asymptomatic. Now, gluten-sensitive enteropathy is another term for celiac disease. Celiac disease is autoimmune type of disorder. Genetically predisposed people may develop, celiac disease if they take gluten-containing food. Okay, this gluten is a type of protein which is present in those type of food. When this protein goes to the GI tract, there is an intensive, reaction in that area, which can lead to destruction of the villi, and this is known as celiac disease. So even if somebody is having celiac disease, if they do not eat gluten-containing food, they will not having any problem. But if they do not know why they are having diarrhea, they continue to eat the same type of food and then do not go to the hospital also, they may be having a lot of, manifestation from celiac disease. The mechanism by which ingestion of gluten induces granular IgA deposition in the skin and blistering is still not known properly. All of these disorders, we really do not know what is the etiology. So they are considered as a type of idiopathic situation. But one of the points we know is, in this condition, IgA type of antibody is mainly affected, rather than IgG. There is a family history of Dermatitis Herpetiformis, a celiac disease in 10% of the patient. So a good history has to be taken. Now, let's talk about the pathogenesis here. The IgA deposits are the gluten dependent and are deposited in the papillary dermis and slowly cleared from the skin once gluten is removed from the diet. This IgA, okay, is the main antibody here. This IgA will be deposited in the papillary dermis. Remember, dermis is divided into two parts, papillary dermis and the reticular dermis. Papillary means the superficial one. So right below the basement membrane, that area is affected. That's why dermatitis herpetiformis is a subepithelial type of vesiculobullous disorder. The autoantibody, which are mainly IgA type, okay, they are developed against tissue transglutaminase, and they are relevant to the pathogenesis of celiac disease as well. These antibodies have been demonstrated in dermatitis herpetiformis too, because it is a part of the same type of disease. So you can also call them anti, or transglutaminase antibody. That is another term we can use here. Formation of IgA antibody against gluten sensitive or gluten tissue transglutaminase, which is known as TTG. This TG for transglutaminase. Okay, this small t is for tissue, which is found in the gut. These antibodies cross-react with epidermal transglutaminase in this case. Epidermal means skin cell. Okay, that's what we are talking here. And that's why dermatitis herpetiformis involves the skin. Okay, so the same patient who is having celiac disease may be having TTG and ETG together. Okay, TTG and ETG, or this TTG may act like ETG as well. So different types of things are there. Now, what is the pathology of this condition? Neutrophils and eosinophils, they accumulate within the dermal papilla and they form microabscess. But remember, there is no microorganism here. This pus collection or abscess is not caused by any infection. Rather, it is caused with a collection of these different inflammatory cells. The surrounding collagen is degraded, resulting in detachment of the epidermis and a subepidermal vesicle formation. This is the pathogenesis of vesicle formation here. Multilocular vesicle may fuse to form blisters. Direct immunofluorescence is always positive. And remember the meaning of immunofluorescence study. Immunofluorescence study is done for the detection of antigen-antibody combination there. So this is one of the example here. In this condition, IgA antibody will go and bind to this dermal papilla. So we can detect it with the help of immunofluorescence study. There may also be C3 and IgG involvement, but IgG is not very common than IgA. Now, this is the histopathology or histology, you can say. See this? Please pay attention. Here is the epidermis. This is stratum corneum here. Okay, these are the flecks of the keratin. These are the superficial layers of the epidermis. You can say this has a basement membrane. See this? And this is the dermis. Okay, this is papillary type of dermis. We call them dermal papilla. Dermal papilla. Look at the gap here. This gap is formed because of the blister formation there. So you can clearly say this is below the epidermis and in the papillary dermis. And if another clue is provided to you, this patient is also having malabsorption because of some problem in the intestine, then you can always correlate the things together and easily can reach to the diagnosis. Sometimes they may give the clue, like the person is having gluten containing food, and after eating that food, the person is having diarrhea. So that's a very, very good type of clue for you. Now, regarding the clinical features, okay, most of the things we already talked about. This is just a revision now. Dermatitis herpetiformis presents mainly between the ages of 20 and 55 years, but can present both during childhood and older age. The onset may be acute or gradual, and pruritus is usually the first and predominant symptom in this type of condition. Pruritus means extensive itching on the skin. The vesicles are usually grouped together on plaques of the erythema and rarely blisters 1 to 2 centimeters in diameter because they are deeper. Okay, we do not easily see them from the surface. The distribution of the lesion is very characteristic here. The extensor aspects of the limb, especially the knee, just below the point of the elbow, buttock, and the natal cleft are affected in the majority of the patient. All of these are from the extensor aspect of our body. And other areas are axillary fold, shoulders, trunk, face, and scalp as well. They may be less common than the extensor aspect of the limb. Now, in our upper limb, which are the extensor aspect and the upper limb? Yes.
The deltoid muscle and back of the forearm, extensor compartment.
Triceps.
Triceps are the extensor of the
Yes. Exactly.
Hand muscle.
of forearm.
Back muscle.
Exactly. Very good. So all of you are correct. Very good. So for that, I will ask the patient to stand in the anatomical position. Okay. We all know what is anatomical position. Now the back side, okay, of the upper limb, the back side when somebody is standing in the anatomical position is called the extensor surface. Extensor surface. So triceps muscle is present on the extensor surface. Very good. Back of the elbow, you can say, okay, back of the elbow where there is olecranon process present. Then the whole back of the forearm and dorsal surface of the hand. All of these are called extensor aspect or surface of the upper limb. Now, similarly, what is extensor surface in the lower limb? Yes, lower limb. Is it exactly like upper limb or is it different?
Opposite.
Exactly opposite. Very good. This is exactly
of the
This is exactly opposite. Just remember that. This is now the anterior aspect of the thigh. Okay, knee, the kneecap or the patella, where the patella is present. This is now the extensor surface. Then leg, okay, the anterior aspect of the leg, shin. This is the extensor surface now. And then the dorsum of the foot again. Okay, never forget this. Sometimes student, at that heat of the moment, you may easily forget these very simple things and make a big mistake there. Now, few of the pictures. Okay, see this? These are extensive skin involvement, but with this simple picture, you can never say this is a case of dermatitis herpetiformis. Okay, so there will be some clues provided to you, of course, and I'll always combine the things together in medicine. These are called different type of pieces. We have to fuse these different pieces together, and then only diagnosis can be made. See this? This is the back of the elbow. Okay, so these are the ruptured type of blisters here, and a very erythematous base. The patient may experience bouts of abdominal pain, okay, diarrhea, and the patient is undernourished. Rather than constipation, the patient is having diarrhea. Constipation may be present in the asymptomatic type of cases, but usually it is associated with diarrhea. Remember that, because celiac disease is associated there. Associated disease are other types of autoimmune diseases here, which we have discussed so many times before. Celiac disease and dermatitis herpetiformis both are autoimmune disorders. So other autoimmune disease may be present in the body of the patient. This sentence you can easily include in Pemphigus vulgaris, Bullish Pemphigoid as well. Okay, nobody can deny it, because all of these are autoimmune diseases. Like thyroid disease are two important conditions from the thyroid gland we always include here. They are Graves' disease and Hashimoto's thyroiditis. Both are autoimmune disorder. Pernicious anemia, which affects the stomach, and then diabetes. Which type of diabetes we include here? Which type? Yes,
type 1.
Type 1.
exactly. Always type 1. Okay, always. Type 1 diabetes is strongly considered as autoimmune, nature. Lymphoma is a well-recognized complication of dermatitis herpetiformis and celiac disease also. T-cell lymphoma is one of the important complications of celiac disease. So it is a complication of dermatitis herpetiformis also. because they are occurring together. So there's some other picture, okay, which are included. Look at the blisters here, and most of these are already ruptured here. Now, at last, what is the treatment? The most important treatment in this case is a gluten-free diet. If somebody is, taking this diet which doesn't have any gluten, then no problem occur whatsoever. Yes, in the beginning there may be some clinical manifestation already occurred in the patient that can be controlled with the help of those drugs which are written, like a topical steroid, okay, even a systemic corticosteroid for a short duration. We can give them and control the clinical features. But what after that? We have to advise for gluten-free diet. Okay, so wheat, barley, and rye must be excluded from the diet because these are the one which contains gluten. Okay, so then what is the option for us? Okay, because large population in this world, okay, they love to eat wheat every day. So if not wheat, then what is the alternative food for us? That is rice. Okay, rice doesn't have gluten. Potato doesn't have gluten. So these are very important alternative food for those people who are having celiac disease. This is the practical information you must know, because you must counsel your patient like that. You cannot only say, oh, you cannot eat that. Patient may ask, doctor, then what can I eat? So you should be able to counsel accordingly. One other drug, okay, is dapsone. We really do not know how dapsone helps here, but dapsone is widely used in the treatment of Dermatitis Herpetiformis. The dose needed for the average case is 100 to 200 milligram per day, and the action is thought to be related to the inhibition of neutrophil migration and function, but the exact mechanism how it is helping here is relatively unknown. Now, can you tell me dapsone is used in which other condition? Which other?
Leprosy. Leprosy.
Very good, excellent. Dapsone is a very important drug in the treatment of leprosy, but this is another use of dapsone. You remember like that. Okay, so at the end, I like to request you all to like the video as much as possible, share it among your friends, and subscribe to the channel so that it will encourage me a lot for the future videos and recordings. Thank you so much.